Welcome to The Patient Physician, a space for doctors to explore their physical, mental, and financial wellness. Your peers and industry leaders will destigmatize institutional perceptions while redefining success, money, and personal care. Get ready to pull back the curtain because here, you are both patient and physician.
Hello, everyone. Welcome to The Patient Physician. I'm your host, Paul Smith.
And I am the co-host, Chris Fulbright, and we are super excited to be meeting with Dr. Dietzek today. Dr. Dietzek, Paul and I had the pleasure of visiting with you just a couple weeks ago, and I got to tell you, we have been excited to have an opportunity to visit with you again. And so thank you so much. We know you have a lot going on, and we're excited to visit with you a little bit more today.
It's great. Nice seeing the both of you.
I'm going to just give a little bit of background, but we'll also attach the bio to this because it's quite extensive. Dr. Dietzek is a board-certified vascular surgeon with more than 25 years of experience and has vast knowledge of vascular disorders, a special interest in carotid. This is why I don't do what you do, right? Peripheral aneurysmal diseases of the thoracic and abdominal aorta. You know, I debated before we even started I'm just going to delete that out. I thought, no, I'll struggle through it. So fail out year one, medical school. He's proud of the fact that the majority of his patients are managed non-operatively, reserving surgery for only those where there is no better alternative. He's a fellow of the American College of Surgeons, a distinguished fellow of the Society of Vascular Surgery, and has held many leadership positions in vascular organizations. He has numerous publications in peer-reviewed journals, and he's the current network chief of vascular surgery for Eastern region of Nuvance Health. He believes that trust and honesty is vital in the patient-physician relationship and allows him to provide personalized, excellent care and treats patients like a member of their family, which we'll see. We'll try to survey some of your family and see if that's a good thing or bad thing later. But in his free time, he also enjoys numerous sports, reading, architecture, and then I may bring up the other thing that you talked to us about later. But he chose vascular surgery because it's a dynamic field of medicine that is technically challenging and can provide the ultimate rewards of saving a patient's life and limbs. So welcome. You and I have really only had a little bit of exchange back and forth when we met doing the DeBakey Sisterhood and Surgery webcast a couple of times. And those discussions were really more centric around financial decision-making and do's and don'ts and things like that. But you are always able to really share great thoughts and wisdom because of your experience. So I just wanted to dig in and go a little bit more personal and share some of the other experiences that you might have had over 25 years. I'm sure you've seen a lot, been through a lot. And if we can start there, that'd be great. Take us through some of the high points.
Some of the high points of my career, I think that, as I reflect, it's been a privilege to be a physician and a vascular surgeon. I remember my first few months coming to work and just like not believing that somebody was actually going to pay for me to play in the sandbox. It was like, wow, it doesn't get better than this. But then as time goes on and you deal with hospitals and administrators, you realize, well, maybe it could get better than this. But I still love the field of vascular surgery and the science of it and the surgery and the technical portions of it. I was at North Shore Hospital before it was even Northwell for 10 years prior to coming to Danbury Hospital, as it was known then, to start a vascular program. And it's been a journey. Now we're 23 years in. It's a 7-hospital system. We've grown a vascular lab that I'm very proud of. When I came here, we did 1,500 studies. Now we do 15,000. We have 4 vascular surgeons in my service. We do lots of advanced procedures. We have hybrid rooms. For those of you who don't know what that is, that's a combined operatory with an imaging unit that's fixed in place in the operating room. so that we can do minimally invasive, what they call endovascular procedures. And about 80% of our operations at this point in time are actually endovascular, or these minimally invasive procedures. And that's remarkable considering that when I started, I couldn't tell you what the word endovascular was because it hadn't been invented yet. So there have been some really amazing changes over the course of the last 25 to 30 years in vascular surgery. And so it's been great to be a part of that. Then there's the academic part of my career, which I thoroughly enjoy, and that's, doing research and presenting our research, around the country and sometimes the world. And so that's also a lot of fun and enjoyable, and you get to meet lots of different people and hear lots of different things and learn about other systems of medicine other than your own. So,
Well, and you were one of the first physicians in the United States to use radio frequency too for treatment of chronic venous insufficiency, and amongst other things that you were talking about, just sort of seeing how medicine has evolved. And so, tell us how that was to be kind of on the front end of something like that. I know you participate in that, on that side of it, with the academic portion, but also part of trials. And so, is there something down the road that you're excited about, that you're researching or studying now, and maybe even starting to teach?
yeah. So, well, what you're referring to is the endovenous ablations, which essentially, when I was a resident and in the first 10 years of my practice, the way we treated varicose veins, which we didn't really know a whole lot about, other than that it meant that the vein that they were attached to, which is the great saphenous vein, which is the main superficial vein in your leg, it's the vein that patients have taken out all the time to do bypass in their hearts or bypass in their legs. And in those days, if you had bad varicose veins, you would strip out that great saphenous vein. You would make a little incision at the groin and a little incision at the ankle, and you'd put this long piece of plastic tubing through the vein and tie it at the other end and then rip it out. And it's just as brutal as it sounds. And this was done under general anesthetic, and the patients would often spend days in the hospital. And then as we progressed, we would even do it as an outpatient, but the patients had a ton of pain. And it was really, people feared having that surgery, which is why there weren't a ton of them done. And then came endovenous ablation, where we now, under ultrasound, would identify the vein at the ankle or the knee and then insert a little tube, a catheter, that heats up with radio frequency. And as you remove that from the vein, and I'm making it very simplistic, but as you remove it from the vein, it closes the vein. And the whole procedure takes about 20 minutes. And the patient walks in and walks out. And then other alternatives to radio frequency were laser. And now there are other means to close the veins with chemicals and glue and foam. And so it's really been a remarkable change. And now patients everywhere have heard about these procedures, and they no longer fear coming in to have this addressed because it's really a minimal procedure.
What the changes that you described there, just it seems so outstanding. We just had a close family member who had, I don't know, it was like 6 bypass. There was already, and that's exactly what happened, right? It was they removed the vein in the leg, and the steps and the sequence of events of healing there. His doctor even said, look, if this had happened several years ago, this process would have been so much more painful, one, but two, that the healing process was so much longer. One of the things that Paul and I have done through the patient physician is had the opportunity to visit with physicians around the country. And one of the questions that continues to bubble up is how AI is affecting both training, but also medicine in your specialty. Where do you kind of see AI coming in from either new procedures or even within patient care?
I see Arnold Schwarzenegger becoming a vascular surgeon and taking over the world. But
I knew there was going to be a sequel.
Yeah.
yeah, and AI is both a remarkable tool that will be to the advantage of many patients in the medical arena. The first I guess specialty that's really going to be affected in a very big way is radiology, because they've already shown now that AI with a period of training can identify diagnostically just about anything and more than a radiologist. So that's unbelievable. So you can imagine how this is going to change things for everybody, and the consideration of thousands and potentially millions of facts regarded to any patient or disease entity to help you make a decision about what the right thing is to do. Now, we all, we talk about the art and science of medicine, and there's no question that at least now AI doesn't have the art part down, but it does have the science part. And, that is going to be a huge advantage. Alternatively, and at the same time, I don't know if you folks saw the recent 60 Minutes where they interviewed the person who invented AI from England. He won a Nobel Prize for it. And he said we should stop right now and reassess. So I think it's going to be, on the one hand, we're going to see it have great advantage in medicine, but who knows if this is going to be allowed to progress unchecked. And I would not be surprised if we see at some point in the not too distant future that they kind of put a hold on this for a while until they can figure out really how to control all aspects of it. It would be great if you could just teach it medicine, but it don't work that way. And
So I didn't catch that episode, but you're seeing that he said something about stopping. Are you talking about in terms of just applications across the board, or how it pertains to medicine?
No, not medicine. In fact, that's one of the things you mentioned. That's where some of the great advantages of AI are going to be in medicine and in teaching. But beyond that, there is the fear that it can get out of control, and we really don't understand it fully. And one of the things I found remarkable was that, I think it was Scott Pelley asked him, well, do you really think the computer can think? And he said, yes.
Wow.
He said, we have ways of testing it. We would ask it a question, and based upon just facts, the answers they get are not what they expected. It is indicating that there actually is some sort of thought process, not self-awareness, but a thought process. And he went on to say that, right now, your typical AI has 1 trillion connections that it's dealing with to make all these assessments. The human brain has 100 trillion. The rapidity with which this is going to develop is going to be mind-blowing, I think. And I think everyone thinks that once AI gets to a certain point, it can write its own code. And so it gets into a very philosophical conversation about, I personally believe in God. On the other hand, part of believing in a superior entity is that humans are different and we have the ability to be self-aware and think. But is it really because we're imbued with a soul, or is it because we have a certain number of neuronal connections that at some point allows you to become self-aware and say, I am? So if that happens with a computer, will they also become self-aware? And at that point, it would be kind of the cat out of the bag, because can't control that. So it's a little scary.
Yeah.
Just something to think about.
Yeah, your thought process then obviously ties back to Terminator and Arnold Schwarzenegger, and what you're describing there can be very scary, right? If we think through the processes and knowledge based and in the different industries, there's still the personal connection, right? When we go in to see a doctor, when we visit with a surgeon, and I think that yes, there's skills and there's reviews and technical part that could come from the computer. Do you feel that a patient's expectations, or I guess it may be more difficult from generationally, thinking back, we didn't come with cell phones, our children grew up with them. There's that a different comfort level there. But within the doctor patient relationship, the AI could do certain portions of it, but the doctor relationship with the patient, do you feel that would be even more important to have people move forward? Or do you see sometime in the future where in certain specialties, the doctor could actually be removed out of that sequence and it's all AI driven?
I do think there will be portions of medicine that will be replaced.
Interesting.
I do, because I think that especially in those fields where there's little patient interaction to begin with, and if it's just, the ability to interpret certain things, I think, like radiology or something along those lines, it is scary to think about, but it is possible that there are certain areas of medicine that could be replaced. I don't think any area of medicine is going to go untouched. You would hope. I know I would want to see a human interact with me. And again, the art of medicine, it's more than just having the facts, it's understanding the particular patient and what their needs are in deciding, what kind of therapy you're going to recommend. So I may be able to tell you that the best operation for you to keep your aneurysm from rupturing is this, this, and this. But I have to understand you and where you are overall in your medical circumstance, your social circumstance, your psychological circumstance, to understand if that would really be the treatment or management for you as a person. And I think we're a ways off from that as far as AI is concerned.
I just want to know how Hollywood knew so far beyond. We knew this was coming.
It
Seem to
is
be writing
remarkable.
our
It really
lives, right?
is quite remarkable to think that 30 years ago somebody really anticipated the potential problem.
Well, and the speed at which it'll continue to develop, it just accelerates even further, right? It's 1 to 2, 2 to 4, and so on and so forth, and it just is a lot more rapid in terms of the growth. But I'm going to shift back a little bit and go to training, where one of the things that we talked about is back where there was heavy training schedules. In fact, we had a conversation just recently with another physician that had also gone through where it was very rigorous and had noted that it was a very big deal when they shifted to having limited hours. And so, if you can kind of talk to that and your experience of going through that, I know that seeing where you had to go through, is it been a good thing to limit those hours from what you've seen? Or do you think that, especially with the development of AI, I know we're kind of layering in different thoughts here, but how does that really evolve the training programs if we have something that's learning a lot faster than we can anyway?
Well, that's a very interesting question. I think that with regards to the training, there's no question that there has been a revolution, not only in the therapies we administer, but in the training that we now receive. I mean, when I was a resident, the average surgical work week was somewhere around, I don't know, 110 hours a week, which don't leave a lot of time for sleeping or doing anything else. And so it was brutal. And at the time, if you would have asked me that, I would have said, this is horrible. This is crazy. And you don't need to do it. Why do we have to do this? Alternatively, I think that it's a different breed of surgeon. I'll only comment on surgeons for now. Sometimes I'll have to do a late case and the staff or nurses will say to me, I don't understand. How could you be awake the next day working? You look like you didn't stay up. And comes from the training you receive. You just get used to it. But it's good and it's bad. I think in the 5 years of training, if you compared that to training today, it's probably you're getting 7 years of training in 5 years. And so, and this has become somewhat of an issue because a lot of the residents finishing their training today need additional training to get to where we were, 25, 30 years ago. That said, currently, the training is more sensitive to a work-life balance. I think, as we all know, the younger people today are more concerned with work-life balance, and that's not a bad thing. Maybe they have it right. I will tell you that despite the fact that they spend less hours doing work at their residency, I don't think there's a week that goes by that I am not impressed with the knowledge and ability to produce by our younger people. I mean, I remember when our parents would say, "Oh, this young people, they're so smart today." And I would say, "What are they talking about? They're not really any different than when you were young." But I'm telling you, when I see these, I'll call them kids now because compared to me, they are. But when I see them presenting and some of the research they're doing and the quality of their presentations and how they write, I'm fascinated by that because I think even my own kids, I'm like, I cannot believe they are as good as they are. So there are pluses and there are minuses. I think we still turn out great doctors. The training's a little different, the attitude's different, but I think we turn out some great doctors. What it will mean in the future as far as healthcare in the United States, clearly it's evolving. Venture capital is involved in managing practices, hospitals are involved, even insurance companies are involved. The latest figure I heard is that United Healthcare, an insurance provider, now owns providers. 70,000 physicians are employed by United Healthcare. I don't know. To me, that's a scary thought. Seems almost like a conflict of interest at some level. I think it's clearly evolving. And do I think patients can expect the same kind of care they once received from their doctor who they love and they trust? And probably not. Probably not. I don't think it's possible if you really want to produce a different kind of work-life balance to maintain the kind of relationship we had with our patients for most of my career.
Do you think that's a US based that you're describing there, or do you see that? I mean, I know that you and Paul met speaking on a platform, and obviously reading through your bio and getting to know you, people reach out to you on a regular basis. What you described there from a training aspect, from a patient interaction, the change in training intensity, maybe the hours. Is that a US based change, or do you see that happening internationally as well?
Well, it's definitely happened internationally. And I think actually Europe is probably further ahead on this than we are.
Okay.
I think uh, their hours were limited much in advance of ours. Also, a socialized system has different nuances to it than a capitalistic
Sure.
one does. And, just by virtue of the fact that, our insurance companies are traded on a stock market. So their fiduciary responsibility is to answer to shareholders, not to patients, even though they're providing a necessary service. So I think there are major differences between the healthcare systems. And I do think that affects training and the day to day of healthcare. I think we're evolving more towards that system. And who knows what the endpoint's going to be? Because right now we're in this crazy arena of venture capital getting involved in buying practices and running healthcare practices in companies that are employing doctors with the specific motivation to produce not quality, but quantity. or profit. And so, how is that? I mean, I don't think doctors are selling their souls, but I do think it changes the dynamic. And, where is that going to end up? Because, just like mergers and acquisitions, all you have to do is go see the movie, what was it, Wall Street in the 1990s? Companies being bought, combined, and sold in parts. Well, you can imagine that as venture capital gets involved in medicine, the motivation is to drive all the profit that they possibly can. And it's going to be at some point at the expense of healthcare, or more likely the persons that work in healthcare. And, I don't think most physicians who are younger physicians are going to enjoy that circumstance.
Well, it certainly displays the motives, right? You didn't get into medicine for the reasons that venture capital does, right? So you're entering into it for two completely different reasons, and we're already seeing where many, even in academia, where a lot of the models have moved to more of what looks like a private practice, where it's, there's some baseline but there's a lot of productivity and RVU based type of income models, and it's starting to look more and more like that. And even in academics, they still have to have a line of profitability. And so some of that edge of where people had selected academics for that work life balance you were talking about has certainly narrowed, I think, because of the demand. And I've talked to several people who over time said, I wanted to be in academics because I liked the ability to teach and be interactive and be on the front end of things. But what's happened now is I have to also satisfy this productivity requirement. And so it's this direct pull where I can't do both equally as good. I have to go in one direction or the other. And so this pure desire to teach and help and educate is getting contradicted by the demand to actually produce. So, where does that go? Does it continue to evolve even more like private practice? And what does that do? When you're already asking so much of the teachers. I want to go back real quick, if we can, to that work life balance, because this was something that I think is continuing to be a huge deal. You had shared an idea about this and what you think should happen, because you had a history of going through your training and having to make some decisions that were not easy because of the demand of your schedule. And so not having the proper amount of time allowed to do the things that you need to do to take care of yourself. It's really, again, kind of the key focus here of the patient physician here, and bringing these decisions. These are not easy, right? And the things that you have to deal with. But you had an idea that I thought was pretty interesting. I don't know if you'd be willing to share that and kind of expand on how that might make things even better.
You'll have to remind me as to specifically what you are referring to, Paul.
Oh, well, good. If you don't remember that, I'm just going to take it, sell it, and then I will mail you.
I'm just not sure which idea you're talking about.
So many good ideas. He wasn't sure which one, Paul. You got
to. I have so many good ideas.
Well, then you're not going to mind if I just borrow this one, and I'll let you know. No, it was Health Day, specifically for physicians, not for you.
Oh, Health Day,
population, just Health Day.
Yeah. We really, I know I'm a victim of this, boy, is that you just put off taking care of yourself because you're so wrapped up in your everyday work of taking care of other patients and doing all the things you have to do to be successful in your own field, whether it be productivity, writing papers, making presentations. And just like, it's not to say that this doesn't happen in every field of endeavor. The difference is we're out there telling patients what they should be doing to keep healthy, and then we don't do it on many levels.
Do as I say, not as I do, right?
Right. And listen, I've been a victim of that. In fact, now the way I make certain that I take care of certain aspects of my health is I just mention to any one of my daughters that I need something done that I haven't done. Like there's something going on right now, or I need a test done. And I can tell you, my daughter she is bothering me every day. Dad, have you made your appointment yet? So that's how I get things done now. But I think that a better way to do it would maybe be to have at least once a month, once every quarter, or twice a year, something called Health Day, where physicians, it's just understood that on that day, you do the things that maybe you need to do to take care of yourself medically, not to go to the town fair, or even though you could say that's a mental day, but really to kind of put it aside to that's a day that you take care of yourself. Now, can't be the same for everybody the same day, because then you'll have no one to go to. Everyone will be out on the same day. But there's got to be a way we can emphasize a work-life balance when it comes to health and the health of physicians. There are just many physicians, as vascular surgeon not far from here who recently passed at a very young age. And I know he worked very hard, and I'm sure that I don't know if there could have been anything to be done to prolong his life, but who knows? I'm sure, like me and many others, we just don't address in a timely fashion some of the medical issues we should be addressing as we get older, or at any age for that matter.
So that just brings up that sort of hovering question of how do you make that happen? You call it Health Day, but there's such a demand on your schedules, and even pulling back in the training, but it just never gets less busy. You've been doing this 25 years. You went through your training. Did it get less busy for you when you got out of training and now you've been practicing?
Well, training in that regard is easy because you're always given a group of things to get done in a certain period of time. You're not in control of your own life. In other words, you're given things to do that are more than any human can do, and that's your mission. And so you do it. Once you finish your training, yes, you have many of those things, but then you have a lot of discretionary time, in the sense that you could elect not to do an extra case, or you could elect not to give that talk, or maybe not write that chapter or do that article. I mean, yes, there are pressures to do that, but it's not the same. It's not the same. And you have to be an adult and make the right decisions. And I'll be the first to say that we don't always act like adults and make the right decisions. So, I think that's the difference. So it's different than training. In training, it's easy. You're giving your marching orders. It's like being in the service. You're a private. You're giving your marching orders, and that's what you do. And if you don't do it, believe me, you'll be in the doghouse and in some kind of confinement that you won't like.
They have a way of getting the behavior they want, right?
Oh, yes.
Yeah.
I mentioned this in the beginning. When people go through and we've seen a few people work an entire career and then think about pursuing other interests. I thought it was interesting that you started to explore. And this was the one I was mentioning earlier, that you were talking about pursuing comedy maybe at some point. I find this fascinating from a couple of different levels. One, because you obviously have a great bio and history, and you do great at what you do. But at what point do you start to think about exploring other things? This career to be a physician demands so much. At what point do you get the choice to start pursuing other interests? Maybe they're not to earn income, but just for enjoyment and really get to explore those. And this is a great one because it allows you to have and access a completely different side of your brain than the one that has to be super critical and serious with the patients, and you're dealing in a very serious atmosphere versus obviously hopefully you're not super serious as a comedian, otherwise I don't think you'll do it very long.
Well, I do comedy as a surgeon. So you're saying that I can't do surgery as a comic?
Well, I guess you could go in and just say, whatever jokes you want. I'm not sure that the patients will stay in the room.
Yeah, I think
They might.
I think you're right. I do think comedy. I think laughter and comedy is an important part of healthy state of being. I use it in my interaction with patients and other professional staff every day, all the time. Not to the point of silliness, but to the point, I think it's just good for you to smile and laugh. Anyone who knows me knows that when I give a presentation, at some point in that presentation, there may be something comical that will appear, something amusing, let's say. Usually, not always, but I do enjoy that, and I've often thought about giving it a go if I ever stop doing what I'm doing, which I don't know if I will, but to get up on a stage and try to actually make people laugh. That that's a daunting task. Takes a whole lot of guts too.
Well, I bet it's a little different than what you currently do. I would not want to get on your stage. That would be not funny for me. I think it's great that you bring that into your work. I think, shoot, there's so much weight in doing what you do and dealing with patients that I'm sure that the patients appreciate somebody that comes in and has a great attitude, or the people that work with you and is even interested in making people laugh. Right, the fact that you lead with that is great. I want you to send us an invitation when you finally decide that you want to go do your open mic night.
Well, as I think I told you, I did it once on a cruise at the urging of my good friend and my family for a talent show. And they convinced me that because this talent show was in the middle of the day, that, no one would possibly be on a cruise ship going to a talent show when it's 90 degrees out rather than being at the pool. And so I let myself think that, okay, well, I could get up and do this in front of 20, 30 people. And only to find out that when I walked into this massive room, it looked like Radio City Music Hall, and there were over 1,000 people in this room waiting to see the talent show.
You did not say that. There's over 1,000 people in the room.
Yes, it was quite intimidating. When I first walked in, I looked at my friend, I said, I am not doing this. I am not. He said, it's too late. You're on the list. You can't not do it. You have to do it.
And
I wrote my own material the day before, and it was all about the cruise so that everyone could appreciate it, and gave a kind of comedy act presentation, and got a standing ovation. The MC looked at me and he said, it's a talent show. You don't get to do an encore. Thank God. I've got no more material. I'm out.
And the next day, the boat had pulled back into shore.
Yeah, right.
So, Dr. Dietzek, we wanted to kind of wrap up. Thank you so much for the time as we go through it. And the name of our podcast is The Patient Physician, and it means different things to different physicians throughout your career. Just saying the phrase, the patient physician, what would that mean to you?
Well, it would mean two things for me. The first thing I think of when you say that is the patient and the physician and the relationship between the two. And then the second thing I thought of is very much what we talked about earlier, and that's the physician as a patient and always remembering what that's like. And I think sometimes we forget. I will tell you that as you get older and you become a patient more frequently, it really puts a shock of reality in you, and it makes you more cognizant of what your patients are going through. Sometimes you have to be a little bit hard to be a physician, and in particular, a surgeon, and in very particular, a vascular surgeon, because we see so much illness and at times death. And you can become numb to it. And you can't do that. You just can't do that. You got to keep bringing yourself back and saying, this isn't a so-called case. This is a patient. When you always bear that in mind, you'll be a better doctor.
Thanks so much for your time. It's good to catch up with you, and I look forward to seeing you on stage.
I'm going to give you a discount.
Perfect.
Thank you, Dr. Dietzek. We really appreciate your time, and we look forward to speaking with you soon.
Thank you, and I enjoyed it.
This conversation was brought to you by Physicians Resource Services, a firm supporting medical professionals to improve their financial situation and pursue their personal and professional goals. The Patient Physician is produced in Austin, Texas. Editing and sound design are in the hands of the PodConnects Podcast Network. Please email questions or show ideas to info@physiciansrs.com.